Welcome to this lecture on wrist, hand, and finger pathologies. This region can look small anatomically, but small injuries can create major problems with grip, pinch, dexterity, catching, throwing, blocking, and daily function. As we move through the presentation, keep asking 3 questions. Where exactly is the pain? What mechanism created it? And what function has been lost? Radial wrist pain after a fall, ulnar wrist pain with rotation, night numbness in the median nerve distribution, and loss of active finger motion all point to different priorities. The goal is to build a safe, location-based approach to evaluation, protection, referral, and return to activity. These objectives frame the lecture. We will use location, mechanism, and functional loss to differentiate common wrist, hand, and finger disorders. We will also identify high-risk injuries that need protection and referral, including scaphoid fracture, tendon rupture, unstable thumb UCL injury, complex dislocation, and fracture patterns. The important mindset is that subtle deficits can matter. A finger that cannot actively flex or extend may represent tendon rupture. Snuffbox pain after a fall can represent scaphoid injury. Numbness at night may point toward nerve compression. Do not treat the hand as a generic pain region. Exact structure and function matter. Use this anatomy slide to orient the wrist and hand before the specific pathologies. The wrist includes the distal radius and ulna, carpal bones, TFCC region, radiocarpal and midcarpal joints, and multiple tendons and nerves entering the hand. The hand adds metacarpals, MCP joints, PIP joints, DIP joints, collateral ligaments, volar plates, pulleys, and flexor and extensor tendon systems. Evaluation requires exact language. Is the pain radial, ulnar, dorsal, palmar, at the thumb MCP, at the DIP joint, or following a nerve distribution? Resting finger posture, swelling, deformity, and fist formation can quickly reveal whether the problem may be serious. The history starts with mechanism and exact location. Ask whether symptoms began with a fall on an outstretched hand, punching, jamming, forced thumb abduction, repetitive gripping, direct contact, or gradual overload. Then ask the patient to point to the most painful area. Radial wrist pain after a fall raises different concerns than ulnar wrist pain during rotation or weight bearing. Ask about swelling, locking, clicking, numbness, night symptoms, grip weakness, pinch weakness, loss of motion, instability, and sport or work demands. Catching, gripping, typing, lifting, blocking, or weight bearing through the hand all change the functional priority. Inspection, motion, and function are essential because small deficits can be meaningful. Observe swelling, bruising, skin integrity, deformity, and the resting finger cascade. Look for mallet posture, boutonniere pattern, thenar wasting, clawing, thumb position changes, rotational deformity, or a finger that does not line up when making a fist. Then assess wrist motion, forearm rotation, digit motion, tendon integrity, grip, pinch, and neurovascular status. Palpation should match the suspected structure. Snuffbox after FOOSH, TFCC region for ulnar wrist pain, MCP or IP joints after jamming, and painful tendon or ligament structures based on location. Choose assessment tools based on the clinical question. Snuffbox tenderness after FOOSH should make scaphoid injury a priority, so palpation, axial thumb loading, protection, and referral planning matter more than proving it is a sprain. Ulnar-sided wrist pain with rotation, gripping, or weight bearing brings TFCC involvement into the differential. Radial styloid pain with repetitive thumb use may suggest Quervain tenosynovitis. Nocturnal numbness in the thumb, index, and middle fingers should lead to median nerve screening. Loss of active DIP extension or flexion should immediately raise concern for mallet finger or jersey finger. Now we move into common wrist and hand disorders. Keep separating fracture concern, ligament or cartilage injury, tendon overload, nerve compression, and tendon rupture. Scaphoid injuries are important because they are easy to miss and may heal poorly. TFCC injuries can create persistent ulnar-sided mechanical pain. Carpal tunnel syndrome is a nerve compression pattern that must be mapped carefully. De Quervain is a radial-sided tendon loading condition. Finger tendon injuries are time-sensitive because position, splinting, and referral influence outcome. The goal is not just naming the diagnosis, it is deciding what is safe and what needs protection or referral. Scaphoid injury is a key concern after a fall on an outstretched hand. The athlete may report radial wrist pain, snuffbox tenderness, scaphoid tubercle tenderness, weak grip, or pain with axial loading through the thumb. This matters because scaphoid fractures can be missed early, and limited blood supply can increase the risk of delayed union, non-union, avascular necrosis, chronic pain, and long-term wrist dysfunction. Early radiographs may not fully rule out injury. If the mechanism and tenderness are concerning, protect the wrist and refer for follow-up imaging or medical evaluation. Do not dismiss it as a simple sprain because deformity is absent. TFCC injury usually presents as ulnar-sided wrist pain. The TFCC helps stabilize the distal radio-ulnar joint and supports load transmission on the ulnar side of the wrist. Symptoms may appear with forearm rotation, gripping, ulnar deviation, lifting, pushing up from a chair, or weight-bearing through the hand. Some patients describe clicking, catching, or a deep mechanical ache. Mechanisms include FOOSH, axial load with rotation, or repetitive loading in gymnastics, tennis, baseball, or lifting. Examine ulnar-sided tenderness, rotation tolerance, grip symptoms, weight-bearing pain, and stability when appropriate. Persistent clicking, instability, or inability to load warrants referral consideration. Carpal tunnel syndrome involves compression or irritation of the median nerve at the wrist. The classic pattern is numbness, tingling, burning, or altered sensation in the thumb, index finger, middle finger, and radial side of the ring finger. Symptoms often worsen at night or with repetitive hand use, cycling, typing, gripping, or prolonged wrist positions. Over time, patients may report pinch weakness, grip difficulty, clumsiness, or thenar symptoms. Map sensation carefully, compare grip and pinch, observe the thenar region, and consider provocative tests as part of the full picture. Differentiate this from cervical radiculopathy, pronator syndrome, and ulnar nerve involvement. De Quervain tenosynovitis is a radial-sided wrist and thumb condition involving the first dorsal compartment tendons, mainly abductor pollicis longus and extensor pollicis brevis. Patients often report pain near the radial styloid with gripping, lifting, ringing, texting, carrying a child, or repetitive thumb use. Pain may increase with thumb motion or combined thumb flexion and ulnar deviation. Palpate the radial styloid region, assess painful thumb motion, compare grip and pinch tolerance, and use provocative testing thoughtfully. The goal is not to force pain, it is to understand tissue behavior. Early care often includes load modification, splinting when appropriate, and progressive tendon loading. Mallet finger, jersey finger, and other tendon injuries are important because they can look small but carry major consequences. Mallet finger usually follows axial load or forced flexion at an extended DIP joint and causes loss of active DIP extension. Jersey finger occurs when a flexed finger is forcefully extended, injuring the flexor digitorum profundus and causing loss of active DIP flexion. This often needs prompt referral. Isolate DIP motion rather than relying only on composite finger movement. Also inspect for open wounds, deformity, rotational malalignment, and neurovascular changes. Suspected tendon rupture should be protected in the appropriate position and referred promptly. Thumb UCL injury occurs when valgus force stresses the thumb MCP joint, such as a fall with the thumb forced away from the hand or the thumb catching on equipment. Patients may report ulnar-sided thumb MCP pain, weak pinch, swelling, bruising, or instability. A complete tear or Stenner lesion can cause chronic pinch weakness if missed, so laxity and endpoint matter. Jammed fingers can also hide fracture, dislocation, collateral ligament injury, volar plate injury, or central slip disruption. Look for deformity, rotational malalignment, major swelling, loss of active motion, and neurovascular changes. Instability, tendon deficit, deformity, or fracture concern should be protected and referred. This section pulls the diagnoses together through clinical reasoning. Location is the fastest organizer. Radial wrist pain after a fall makes scaphoid injury a priority. Ulnar wrist pain with clicking or rotation pain raises TFCC concern. Median nerve symptoms at night point toward carpal tunnel syndrome or another nerve source. Thumb MCP pain after valgus stress requires UCL assessment. Loss of active DIP motion requires tendon integrity testing. From there, connect location to mechanism, swelling, deformity, tendon function, nerve distribution, and sport or work demands. Management depends on whether the structure is stable, function is preserved, and the injury is time-sensitive or high risk. Use this matrix as a quick clinical map. Radial wrist pain includes scaphoid injury and Quervain, but the mechanism separates them. FOOSH with snuff box tenderness is fracture concern. Gradual radial styloid pain with repetitive thumb use is more consistent with tendon overload. Ulnar wrist pain suggests TFCC or ECU-related irritation when rotation, clicking, or weight-bearing reproduces symptoms. Median nerve distribution symptoms suggest carpal tunnel or another median nerve source. Thumb MCP pain after valgus stress requires UCL screening. DIP and PIP injuries require tendon, ligament, fracture, and dislocation screening. Let location guide your first questions and palpation targets. In this case, a soccer goalkeeper falls on an outstretched hand and later reports radial wrist pain. Snuff box palpation is clearly tender, grip is weak, and there is no gross deformity. Treat this as possible scaphoid injury until proven otherwise. The absence of obvious deformity does not make it safe to ignore. The mechanism, pain location, and tenderness are the major clues. The next step is to protect the wrist, restrict activity, and refer for appropriate imaging or medical evaluation. The athlete should not return simply because wrist motion is possible or swelling is mild. Document the mechanism, snuff box tenderness, grip limitation, neurovascular status, and referral recommendation. In this case, a desk worker and recreational cyclist reports numbness into the thumb, index, and middle fingers that is worse at night and after long rides. That distribution supports possible median nerve compression, consistent with carpal tunnel syndrome. Clarify wrist position during cycling, keyboard and mouse use, sleep positioning, symptom duration, weakness, clumsiness, and whether symptoms travel from the neck or forearm. The exam should map sensation, compare grip and pinch, observe thenar muscle appearance, and assess whether sustained wrist positions reproduce symptoms. Management may include activity and position modification, ergonomic changes, night splinting when appropriate, and referral if symptoms progress or weakness appears. Management across wrist and hand conditions should focus on structure, stability, and function. Many injuries here are function limiting, even when pain seems modest. Grip, pinch, dexterity, writing, catching, blocking, racket control, stick handling, and weight bearing through the hand all matter. Protected motion, edema control, tendon gliding, joint mobility, and progressive strengthening are common rehab themes, but the plan must match the diagnosis. Tendon rupture, unstable thumb UCL injury, suspected scaphoid fracture, complex dislocation, or traumatic deformity should not be managed like a simple sprain. Return requires stability, symptom control, strength, dexterity, and sport-specific tolerance. The key takeaway is that exact location and functional loss drive wrist, hand, and finger evaluation. Radial wrist pain, ulnar wrist pain, median nerve symptoms, thumb MCP pain, and DIP or PIP motion loss each lead to different priorities. Do not miss time-sensitive or high-risk injuries such as scaphoid fracture, tendon rupture, unstable thumb UCL injury, fracture dislocation, rotational deformity, and progressive neurologic symptoms. A small injury can have a large impact when it affects grip, pinch, tendon integrity, or nerve function. Return to play should reflect tissue healing, stability, pain response, dexterity, and sport-specific demands. These references support the anatomy, examination principles, fracture recognition, tendon and ligament injury concepts, nerve compression patterns, and management reasoning used throughout this lecture. Use them to review scaphoid injury, TFCC pathology, carpal tunnel syndrome, de Quervain tenosynovitis, mallet finger, jersey finger, thumb UCL injury, and return to activity principles. Good clinical reasoning combines detailed history, exact location, inspection, tendon integrity testing, neurovascular screening, red flag recognition, and appropriate referral decisions. The hand may be small anatomically, but it carries enormous importance for sport, work, and daily function.